What's better than listening to the Radiology Review?
Nothing.
Well, true. But you could buy our book, The Board Exam Study Guide, Episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version. Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will discuss nuclear brain imaging with a focus on dementia. I will post a free downloadable study guide on this topic, which you can access for free at theradiologyreview.com. And I want to give a quick reminder to follow at RadRevPodcast on Twitter or Instagram, where you can keep up with the latest announcements and receive free educational content that I am currently posting most days. There is a lot to cover on this episode, so without further ado, let's get into the questions and answers. Let's start with two neuroanatomy questions pertinent to nuclear brain imaging for dementia. First, where is the precunious located in the brain? And that is Precunious, precunious. Where is this located in the brain? The precunious is located in the medial aspect of each parietal lobe, anterior to the cuneus, which is in the superior aspect of the occipital lobe. As a simplification, remember that the precunious is essentially the medial aspect of the parietal lobe just in front of the occipital lobe. Normal or abnormal uptake in the precunious on FDG PET is of importance for dementia imaging, so make sure you know where this is. Look up images on your own to drive this home if necessary. Next question. Where is the posterior cingulate cortex located in the brain? The posterior cingulate cortex, often simply called the posterior cingulate, is part of the cingulate gyrus. This is located medially in the brain near the midline and is located just above the corpus callosum and anterior to the parieto-occipital sulcus. As a simplification, if you look at the part of the brain that is just above the posterior aspect of the corpus callosum near the midline, that is where the posterior cingulate resides. Normal or abnormal uptake in the posterior cingulate is of importance for dementia imaging on FDG PET. Make sure you know where this is and look up images on your own to drive this home. To review, the precunious and posterior cingulate are both located in the medial aspect of the brain. On a sagittal view, the posterior cingulate will be just above the posterior aspect of the corpus callosum, and just above the posterior aspect of the posterior cingulate will be the precunious. I did want to review the anatomy of those two locations because it is important that you recognize where these are and are able to identify whether uptake in these regions is normal or abnormal when considering FDG PET imaging of the brain for dementia. The key for nuclear medicine dementia imaging on radiology board exams is to remember patterns of hypometabolism in the brain for each dementia diagnosis when considering FDG PET imaging. This is not easy to do and requires repetition and study. My goal is to help drive home some of these classic patterns of dementia on FDG PET to help you succeed on these questions on radiology and nuclear medicine board exams. Now, there are exceptions to some of the basic patterns and many variant presentations that exist, but I am going to keep this review focused on the more common, classic, and potentially testable concepts for board exams. Next question. For dementia imaging, what diagnosis is suggested on FDG PET of the brain when decreased uptake is seen in the frontal lobes and temporal lobes? The answer I am looking for is frontotemporal dementia. This is very appropriately named relative to FDG uptake that characteristically shows hypometabolism in the frontal and temporal lobes. therefore frontotemporal dementia. Next, for dementia imaging, what diagnosis is suggested on FDG PET of the brain when decreased uptake is seen in the left temporal region with normal uptake elsewhere? The answer I am looking for is semantic dementia, and that is suggested when isolated hypometabolism on FDG PET is seen in the left temporal region with no anatomic explanation for this finding, such as stroke or a mass lesion. Now, on its own, this would be a nonspecific imaging presentation, but if clinical features are present that could support semantic dementia and an FDG PET is performed for dementia, and you see isolated left temporal region hypometabolism, semantic dementia is one of the differential considerations. Next question. For dementia imaging, what diagnosis is suggested on FDG PET of the brain when decreased uptake is seen bilaterally in the precunious and temporal regions of the brain? Hypometabolism on FDG PET of the brain that is seen bilaterally in the precunious and temporal regions suggests a diagnosis of Alzheimer's disease, dementia with Lewy bodies, or posterior cortical atrophy. Now, it may be tempting when you see this pattern on FDG PET to hone down on the diagnosis of Alzheimer's disease, but you need to remember that there is still a differential diagnosis for this specific imaging pattern with bilateral precunious and temporal hypometabolism, and that is again Alzheimer's disease, dementia with Lewy bodies, and posterior cortical atrophy. Next question. If Alzheimer's disease, dementia with Lewy bodies, and posterior cortical atrophy all classically present with decreased bilateral uptake in the precunious and temporal regions of the brain, what additional features on FDG PET of the brain can help differentiate between these entities? Let's first discuss Alzheimer's disease. If you also see decreased uptake in the posterior cingulate and normal occipital lobe uptake, this favors Alzheimer's disease over dementia with Lewy bodies. In terms of dementia with Lewy bodies, decreased occipital lobe uptake is a characteristic feature on FDG PET of the brain for dementia with Lewy bodies. In terms of posterior cortical atrophy, decreased uptake in both the posterior cingulate and occipital lobes favors posterior cortical atrophy. You may need to review that in writing. If so, please download the free study guide at theradiologyreview.com. And let me summarize here the classic imaging features on FDG PET imaging of Alzheimer's disease, dementia with Lewy bodies, and posterior cortical atrophy one more time to hopefully help clarify the similarities and differences between these three entities. With Alzheimer's disease, you expect to see bilateral decreased uptake in the precunious, temporal, and posterior cingulate regions with normal occipital lobe uptake. I expect on board exams that frontal lobe uptake would probably be shown as normal, but frontal lobe hypometabolism can be seen with even early-stage Alzheimer's disease, but is typically not included in the classic pattern of Alzheimer's hypometabolism because the frontal lobe uptake is variable. In terms of dementia with Lewy bodies, expect to see bilateral decreased uptake in the precunious, temporal, and occipital lobe regions with often normal or less commonly abnormal posterior cingulate uptake. With posterior cortical atrophy, the classic presentation on a board exam question would be bilateral decrease in uptake in the precunious, temporal, posterior cingulate, and occipital lobe regions. Posterior cortical atrophy essentially has decreased uptake in all of the more posterior regions, hence posterior cortical atrophy, and the name can help you remember this. In contrast, Alzheimer's disease classically has normal occipital lobe uptake and dementia with Lewy bodies may or may not have posterior cingulate uptake. Next question. If following FDG PET of the brain, one cannot differentiate between Alzheimer's disease and dementia with Lewy bodies with confidence, what additional nuclear brain imaging test could be performed to help differentiate between these entities? The answer is one of my favorite nuclear medicine exams, which is dopamine transporter imaging, which utilizes I-123 ioflupane. This is sometimes simply called a DAT scan. If dopamine transporter imaging is abnormal, meaning abnormal uptake is seen in either or both caudate and putamen, then dementia with Lewy bodies would be confirmed. If uptake is normal in the caudate and putamen, this supports Alzheimer's disease. So remember that sometimes FDG PET can only get you so far, and if after FDG PET of the brain for dementia, differential considerations still include Alzheimer's disease and dementia with Lewy bodies, one can then perform a DAT scan to see if there is evidence of a dopamine transporter deficit, which, if present, would support dementia with Lewy bodies. Next question. For dementia imaging, what are classic imaging patterns on FDG PET of the brain for primary progressive aphasia? The answer I am looking for is that isolated hypometabolism in the left frontal lobe with normal uptake elsewhere can be seen with primary progressive aphasia. A more advanced concept that is likely beyond the core exam is that logopenic, or is it logopenic? I'm honestly not sure. Primary progressive aphasia also exists, wherein left precunious and left temporal hypometabolism is seen. This is considered a left-sided variant of Alzheimer's disease. One more time, isolated hypometabolism in the left frontal lobe in the appropriate clinical setting would make you consider primary progressive aphasia, and left precunious and left temporal hypometabolism, essentially a left-sided Alzheimer's disease presentation on imaging, can be seen with something called logopenic primary progressive aphasia. Next question. For dementia imaging, what are classic imaging patterns on FDG PET of the brain for corticobasal degeneration? The answer I'm looking for is that hypometabolism in the frontal lobe, basal ganglia, and primary sensory motor cortex is the pattern associated with corticobasal degeneration. Next question. For dementia imaging, which diagnoses are suggested with occipital lobe hypometabolism? Occipital lobe hypometabolism is classically seen with both posterior cortical atrophy and dementia with Lewy bodies. More specifically, abnormal occipital lobe uptake on FDG PET with these diagnoses would typically manifest with more severe loss in the lateral occipital lobe cortex and relative sparing of uptake in the medial occipital cortex, which is the primary visual cortex. And this relative sparing of uptake in the primary visual cortex and abnormal uptake more laterally has been termed the occipital tunnel sign. There is also something called the cingulate island sign that exists when one sees decreased occipital lobe uptake combined with preserved posterior cingulate uptake, and that would support a diagnosis of dementia with Lewy bodies. I understand that these are very difficult patterns to memorize in entirety. These are not common diagnoses that you see every day in the reading room, yet these can be highly tested, and my goal here is to give you an introduction to these patterns of dementia on FDG PET, provide a free downloadable study guide where you can review these patterns in written form. Now let's conclude this episode by talking about amyloid and tau PET imaging. A review of nuclear brain imaging of dementia would not be complete without discussing amyloid and tau PET imaging. You should recognize that there are various names for the amyloid PET imaging agents. So if you see one of these in a question stem or answer list on a board exam, you will recognize these as amyloid PET imaging agents for dementia and Alzheimer's disease. These include C11 Pittsburgh, compound B, which I think of as essentially the original agent, as well as the newer and probably more likely to be tested agents, which are fluorine 18 flutamidamol, fluorine 18 fluorobetapir, and fluorine 18 fluorobetaben. Each of these agents bind and show uptake at sites of beta amyloid deposition and allow for amyloid deposition to be detected in the brain on imaging without the necessity of autopsy, which can clearly be advantageous. In terms of tau PET imaging, I would be aware that these agents exist and are being studied for the diagnosis of Alzheimer's disease and other so-called tauopathies, such as progressive supranuclear palsy. One example is fluorine 18 fluorotaucipir. Let's move on to two final questions on amyloid PET imaging, and then we will conclude this very dense review of nuclear brain imaging for dementia. Next question. What are classic imaging features on amyloid PET imaging to suggest a diagnosis of amyloid deposition and therefore Alzheimer's dementia? On amyloid PET imaging, one is looking for increased cortical uptake with loss of normal gray-white matter differentiation as evidence of a positive scan. Note that there are at least 3 FDA-approved amyloid PET agents, and there may potentially be more depending on how far in the future you are listening to this episode, and each of these have differences in uptake and abnormal interpretation criteria. Therefore, agent-specific reader trainings exist and must be followed for clinical use of these agents. However, a common theme that may be helpful for board exam questions is to look for loss of the expected gray-white matter contrast, wherein a normal scan shows white matter with uptake above that of the cortical gray matter. However, when amyloid deposition is present in the cortex, you will start to see uptake in the cortex, and the gray-white matter differentiation can be lost, and that supports amyloid deposition being present in the gray matter cortex and a positive scan. Preservation of gray-white matter differentiation is evidence of a normal or negative amyloid PET scan. Uptake in the cortical gray matter that extends to the periphery of the brain with loss of gray-white matter differentiation is evidence of an abnormal or positive study. Now, the number of positive cortical regions to confirm a positive scan varies between radiopharmaceuticals, as does the definition of region positivity, so one must refer to the manufacturer guidelines for more specific interpretation criteria. That being said, I wouldn't expect on an exam like the core exam that they would expect you to know the differences between these agent-specific criteria for each of the currently approved FDA PET amyloid imaging agents. Last and final question for this episode. True or false? Cognitively normal individuals can have an abnormal amyloid PET scan. The answer here is true. Up to 25% of cognitively normal individuals will show amyloid deposition on an amyloid PET scan. However, that does not mean this scan is without potential value. A positive amyloid PET scan in the appropriate clinical setting can support a diagnosis of Alzheimer's dementia through confirming amyloid deposition, but a negative amyloid PET scan makes a diagnosis of Alzheimer's disease unlikely. What I've reviewed here is geared towards radiology board exam preparation, and for any of you who will be reading amyloid PET in the clinical environment, it is imperative that you complete and follow the instructions of the reader trainings for the specific radiopharmaceutical or radiopharmaceuticals that will be used at your institutions. That's enough for now. I hope that this information is helpful for many of you. Remember to download the free study guide on this and other episodes available at theradiologyreview.com. Consider following at RadRev Podcast on Twitter or Instagram. And as always, keep up the good work and study hard. Remember that you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.